Celiac disease. Celiac disease is a common chronic malabsorptive disorder. It's caused by an immune reaction to dietary gluten that occurs in genetically susceptible individuals. This chronic inflammation damages the small intestine and ultimately leads to symptoms of malabsorption. Gluten is a protein found in wheat, barley, and rye. After gluten is consumed, it's broken down by enzymes into peptides, including gliadin. Gliadin passes across the small intestinal epithelium and into the lamina propria, where it is deamidated by an enzyme called tissue transglutaminase. Removing an amide group makes gliadin more immunogenic and allows it to strongly bind the MHC molecules HLA DQ2 and DQ8 on the surface of antigen-presenting cells. Celiac disease occurs almost exclusively in individuals with HLA DQ2 and DQ8 alleles, which suggest that the molecules play a key role in the pathogenesis. The gliadin antigen is then presented to CD4-positive T cells, activating them to release pro-inflammatory cytokines like interferon gamma. This results in injury to the intestinal epithelium. The T cells can also activate B cells, causing them to differentiate into plasma cells. The plasma cells release antibodies such as anti-tissue transglutaminase, anti-gliadin, and anti-endomysial antibodies. These antibodies may contribute to the intestinal mucosal damage, but it's important to note that they're key markers of disease and are often used in diagnosis, as we'll discuss later. Finally, gliadin can cause intestinal epithelial cells to produce cytokines that lead to an increase in cytotoxic T cells within the epithelium. This results in epithelial damage. The damaged epithelium ultimately allows even more gliadin to pass into the lamina propria, worsening the cycle of inflammation. Over time, the inflammatory response results in atrophy of the small intestinal villi. It primarily affects the duodenum and proximal jejunum, where gluten is the most concentrated. The epithelial damage and loss of surface area impairs absorption of nutrients. In children, classic celiac disease presents after introduction of gluten into the diet, usually between age 6 to 24 months. Patients can have diarrhea, abdominal pain, irritability, weight loss, and failure to thrive. In adults, celiac disease can cause a variety of symptoms. Gastrointestinal symptoms include diarrhea and steatorrhea, which is pale, greasy, loose stools due to excess fat. Patients can also have abdominal pain, bloating, flatulence, and weight loss. Some may have symptoms of specific vitamin or mineral deficiencies, such as microcytic anemia due to iron deficiency, or osteopenia due to vitamin D deficiency. A subset of patients present with a characteristic rash called dermatitis herpetiformis. This rash consists of red, itchy vesicles that appear symmetrically on the elbows, knees, upper back, and buttocks. It's caused by IgA antibodies that cross-react with epidermal transglutaminase. The subsequent inflammatory response leads to the characteristic blistering lesions. Dermatitis herpetiformis is strongly associated with celiac disease. There are two main tests that can help make the diagnosis. Serology can be used to detect elevated levels of certain antibodies associated with celiac disease, such as antibodies against tissue transglutaminase or deamidated gliadin. Small intestinal biopsy can then confirm the diagnosis. The earliest finding is intraepithelial lymphocytosis, which is an increase in lymphocytes in the epithelium. With time, we see progressive villus atrophy, or shrinkage of the villus height. Compare this to the finger-like villi seen in the normal small intestine. The third characteristic feature is crypt hyperplasia, or elongation of the crypts. This occurs as the cells in the crypts proliferate in order to replace the damaged enterocytes. The treatment of celiac disease is to remove gluten from the diet. Following a gluten-free diet can not only improve the patient's symptoms, but also help to normalize the biopsy and serology results over time. Patients with celiac disease have a higher risk of certain malignancies, such as small intestinal T-cell lymphoma and adenocarcinoma. If a patient is adhering to a gluten-free diet but develops worsening symptoms, consider evaluating for malignancy. To sum up, here are the key points to remember. Celiac disease is a common chronic malabsorptive disorder. It results from consumption of dietary gluten, which in genetically susceptible individuals leads to inflammation that damages the small intestinal epithelium. This causes the villi in the small intestine to flatten and leads to symptoms of malabsorption, including abdominal pain, diarrhea, steatorrhea, and weight loss. Some patients may also have symptoms of nutrient deficiencies, such as anemia or osteopenia, or a characteristic rash called dermatitis herpetiformis. The diagnosis is typically made by serologic tests, including testing for anti-tissue transglutaminase antibodies, as well as biopsy of the small intestine. The primary treatment is adherence to a gluten-free diet.